He's been replaced by Dr. Pooja Kamar, who's going to represent him, and she's going to present on new diagnostic modalities.
So a very good morning to all. Privileged to be in a session with stalwarts in keratoconus from whom we learn every day. And Dr. Shetty couldn't be here because he's stuck in traffic. So he's requested me to replace him. I hope I can do justice to what he would have come here and spoken. So the topic here is newer diagnostic modalities in keratoconus. So we do know that we have already existing technologies like Pentacam, Cirrus, and Galilei, which gives us beautiful indices when it comes to diagnosing normal, suspect, and keratoconic eyes. So they are there, but are this enough? We do have a lot of, like this is just going to give an information about the overall corneal topography, curvature, corneal thickness. But the thing is, we have a lot of other structures. We need to look at, when it comes to keratoconus, we need to look at epithelium, stroma, biomechanics, which Dr. Suzuka has already covered beautifully, so I will not go in depth into it, collagen imaging and biomarkers. It's not just about topography or indices, it's much more beyond it. So let's see what each of these parameters or diagnostic indices has hold for us in current day technology or current day practice and in future as well. So coming to epithelium, we do know that epithelium holds a very important role in when it comes to keratoconus, and epithelium will be quite regular in a normal patient, but when a patient has suspect keratoconus or the patient is developing keratoconus or has keratoconus, you see this classic sign of donut pattern in keratoconic eyes. If this is what you see, like you see a C pattern here, you see a blue area here surrounded by a green area. This is called a C sign. This you usually see when the patients have suspect keratoconic eyes or they are developing keratoconus. But in patients with frank keratoconus, you'll see a donut sign. So epithelium actually helps us to pick up what you are looking at, whether you're looking at a normal, suspect, or a keratoconic eye. And it's not just the epithelium thickness or the epithelium mapping. Epithelial aberrations, there are aberrations on the epithelial layer as well. So those epithelial wavefront aberrations also gives you a picture about whether you're looking at a normal epithelium or an abnormal epithelium. For example, if you see this case on the left hand side of your screen, you can see that the epithelium only has an aberration of 0.5 diopters. So this 0.5 diopters is not the entire patient refraction, it's just coming from the epithelium of the patient. And on the right side of your screen, there is no cylinder. And if you see the aberrations of coma, spherical aberration, and trefoil, they will be much higher in this in the epithelium of these patients compared to those of normal eyes. So that just means epithelium is contributing to the cylinder power, and you do see higher degrees of vertical coma and spherical aberration in the patients of this epithelium compared to others. So yes, this does help you in identifying early keratoconus cases. Frank keratoconus cases, yes, you do know that the aberrations are on the higher side, but epithelium can help us in differentiating suspicious from normal corneas, and it can also help us in pick up early subtle changes in these cases. So that does have an important role. Now, corneal nerves are plays a very important role in your cornea, but let's see what impact does it have in keratoconus and cross-linking outcomes. The top layer, what you see is what the healthy nerves look like. You can see nice nerves, and they're branching well. But whenever there is a keratoconus disease, these nerves do get inflamed and they start thinning out, and gradually they start fading away. So this is a typical sign what you might see in keratoconic eyes. And in addition to it, you will also see cells. You can see these white reflective cells on the surface. These cells are nothing but dendritic cells, and dendritic cells are nothing but the inflammatory cells which are present somewhere in periphery of the cornea. They are normally present, but whenever there's an active inflammation, the cells get activated and they come in the center of the cornea, and it's a classic sign of inflammation. So again, you do see dendritic cells immature or mature in cases of keratoconic eyes at times. And if you have a tool of confocal microscopy, you can study this beautifully and see what you're dealing with. Now, what is the role of this nerves? Why are we talking about nerves? Nerves, as I said, this cells are just a sign of inflammation, and this is what a surface would look like. Your inflammatory molecules like MMP9, IL-17, IL-1 beta 6 might be on the higher side. And if you do cross-linking on these patients have much higher chances of developing haze or scar post cross-linking. So why does it come into picture? If there is pre-existing inflammation present, if you do a cross-linking, they have much higher chances of progression. And if you do cross-linking on this inflamed eyes without pre-treating them, they have much higher chance of developing haze or progression, and they will have poor cross-linking outcomes. So that's why it is important to look at that as well. So second comes the stroma. Posterior elevation is known to be there in keratoconus disease, but does the disease starts always posteriorly? The answer is no. The newer evidence does suggest that the disease does start at the stromal elevation layer, and this is how the normal stroma would look like. It's entirely green. That means it's a normal surface. But if you see any yellow or red areas present, means there's stromal elevation present. And if you have a tool which can do a stromal imaging, then you can pick up early cases as well. And it does not just help us in knowing early cases, but it also helps us in diagnosing or differentiating true progression from pseudo progression. For example, this is a case. You can see this is the topography of patient first visit and second visit, classic progression. But let's see what the deeper signs are. This is the epithelium map. This is what I was talking about. In early cases, the epithelium will be of C sign almost, but as it progresses, it does become a frank donut sign. And this is the stromal elevation map. You can see little bit of stromal elevation present, and in a true progression, you will see that the progression also happens on the at the stromal elevation layer. But that's not always the case. Now here you see steepening on the stroma, but you don't see, here you again see the corresponding elevation notice at the stromal level, but this is the second case where you actually see the stroma is not changing at all. So you do identify cases where there is a true progression or not just the topography where the elevation is happening, but also if it's happening at the stromal level or not. I will not dwell into biomechanics because ma'am has already covered into detail, but of course it helps into identifying differentiating keratoconus from first stage keratoconus cases. It helps us to stage the keratoconus and assess progression, and it helps us in identifying the post-refractive surgery ectasias as well. CBI and TBI, you do have the stress strain index as well. And this is where biomechanics comes into picture. So this is one of the newer modalities which we have to be careful of, which we can look into. But what's going to be the future is Bruin microscopy. Bruin microscopy is nothing but it actually gives a three-dimensional biomechanics of the eye, and it gives the heat map, which is the true biomechanics of each of the point of the cornea. It's a technology which is at the research level, but slowly and steadily it will come into our practice as well. So in Bruin microscopy, you'll see how the mild keratoconus and advanced keratoconus looks like. As I said, it's an indirect heat map. So normal eye looks like all blue. In mild keratoconus cases, you can see that it's becoming green, and in advanced keratoconus cases, you can see areas of red. That means it's picking up the weakness in a different way. And this is how the maps look into our practice. We do have started working on the Bruin microscopy recently, but the data is too early to share. But this is how the maps will look into in our practice as we move on. Something very interesting which is coming up is collagen imaging. Now, stroma is it comprises of collagen. There are collagen bundles present in the cornea, which are responsible to maintain the strength and the shape of the cornea. And if the collagen fibers are weak, or if they are not held properly, they start slipping away, and that's when you develop the keratoconus disease. So that's why collagen is very important structure of the stroma, and a good collagen distribution and density is very important to maintain the strength of the eye. And lesser it is, or it starts slipping away, that means that's when your keratoconus disease starts to set in. So this is how it looks like. This is collagen bundles, and better the collagen, better the outcomes you will have with your cross-linking disease, cross-linking treatment, and lesser the collagen, the outcomes might be suboptimal as well. But do we have a tool to image that? The answer is yes. We do now have polarization sensitive OCT. What the principle of it is that the polarized light is thrown onto your cornea, and all the structures of the cornea will refract the light back, but the stroma will take the bifringence property of this polarized light, and then that's how you'll get the density and distribution of the collagen in your eye. So we've built a custom built polarization sensitive OCT in collaboration with University of Vienna. This is how it looks like now, but gradually it will look like one of your other OCTs in the practice as well. And this is very beautiful what you see. So now this is something which we all know, the biomechanics and topography. But what does collagen imaging give you? So this is how a normal map would look like. Darker the blue or denser the blue or violet means the collagen distribution and density is good. It's better and it's in a good and optimal quantity. But as I said, the patient starts developing form first keratoconus or an frank keratoconus, there is partial loss of orientation and arrangement of collagen. This is how a form first keratoconic eye would look like. And in a keratoconic eye, you'll see there is complete loss of orientation and arrangement of the collagen. So this is like at this point of time, if you want to know how the collagen is, you can only excise the tissue, be it epithelium or stroma, and you have to do gene expression analysis in your lab. But once you have this tool in your practice, non-invasively, just with a diagnostic technique, you'll be able to know how the collagen orientation and densities for a particular eye, just like a topography, and it will give much in-depth value. And it has applications in stable keratoconus case. Now this is a case example where the topography is stable, but we do not know whether the topography is telling us the truth or not. So you can see that this is the OSI, both the eyes OD and OS. This is the first sitting and this is the second sitting. Without doing any cross-linking, you can see how the collagen bundles are orienting properly. So that means this is a case of stable keratoconus which you are looking at. So whenever you have doubt on topographies, this tool does come into picture and tells you whether it's a true picture what you're seeing on topography or not. And you can also identify the progressor keratoconus cases as well. This is the first sitting, this is the second sitting. You can see the collagen here, it's darker blue colors, here it's becoming light blue. And the Bowman's layer also, we all know Bowman's layer is very important, and Bowman's transplantation does have a role in keratoconus management. You can see that the Bowman's layer is also here, it's green, here it's become more of blue, so that means it's thinning out. So it does give you and here also you can see progression. So beyond topography, it also gives you information about how the Bowman's layer is, how the stroma is, and how will you intervene, at what time will you intervene for keratoconus cases, or for cross-linking or transplant, and what is going to be the prognosis. Looking at topographies nowadays, you cannot actually tell whether you are going to have, after cross-linking, whether the patient will be stable, progress, or it's going to fail, right? So collagen imaging actually can give you a better picture, because if it's a weaker collagen, the cross-linking effect might not be optimal, and if it's a good collagen, it will be optimal. So that is how the polarization sensitive OCT will help us into practice. Now, biomarkers. Biomarkers is nothing but the inflammatory cells which are there on the surface of your eye. Now, if you see this two videos, the left side and the right side, just concentrate on this area. When I put the cursor, it will go away, but I just want to then move it here and this area, okay? So you can see that one cell is being engulfed by the other cell and it's being eaten away. And on the other side, you see that the cell is just there. It's not being eaten away by the other cell. And the morphology of the cells, what we have studied in our school, is very good here and there. You can see the margins of the cell are not very good. So what does this show? Whenever in a normal human body, whenever the dead cells are there, a normal cell will engulf the dead cell and throw it out of the body to create space for the new cells to grow. But
Is it the relationship in dry eye and keratoconus?
yes, we do have. So yesterday only I presented the work.
Oh, okay.
So basically this kit is developed for dry eye disease, but we have chosen panel of biomarkers such that it can cover at least 15 diseases which are there, including the retinal diseases. So IL-17, MMP9, IL-1 beta, IL-6, IL-10s, ICAM also. We have ICAM also in our kit. They are the ones which are primarily involved in dry eye disease. So, and we have already developed a AI-based software which will help us differentiate the normal, suspect, like normal or subclinical inflammatory dry eye diseases. And it will tell us also what treatment to give to the patient and not. And why we have chosen this 8 biomarkers to begin with, because we already have treatments in market for this biomarkers. So
with
that's
your
why.
program, can you, is that can it reclassify the dry eye types or classify?
Yes. If it would have allowed, I would have shown a slide. But yes, it can differentiate a control, aqueous deficient dry eye, and evaporative dry eye. For example, ICAM is a molecule what you'll see deranged in Sjogren's disease, and IL-17 is the one you'll see in pain without stain. So yes, we do have biomarkers as well which will differentiate each of these conditions, and it will also tell us if it's a mixed variety or an evaporative dry eye disease or an aqueous deficient.